Hi, Muhammad Al-Mala here with another case of a patient with cataract surgery in a small pupil. As you can see here, the pupil actually is not that small. It's probably about 5 millimeters or so. But when I'm seeing a patient in clinic, if they do not completely dilate, I always make a note to myself of how much the pupil actually dilated. And I like to have a plan before I get to the operating room of how I plan to manage when the pupil does not dilate all the way. In a case like this where the pupil dilates about 5 millimeters, I do not use any pupillary expansion devices. But the final decision is made when I have placed the viscoelastic into the anterior chamber and we've achieved viscodilation or viscomydriasis. At that point in time, I'll make a decision as to the size of the pupil and whether or not I want to use a pupillary expansion device or iris hooks. So as we can see here, the case is progressing nicely. We're doing the continuous curvilinear capsulorhexis. I'm using my 0.12 forceps to grab the paracentesis and get rock solid stabilization of the globe. The patient may try to move right and left, but with the 0.12 forceps there, you're not going to get any movement. Here I'm decompressing the posterior lip of the wound. Why am I doing that? In order to try and prevent iris prolapse. Whenever you have a small pupil, it doesn't dilate well, the iris is going to prolapse when you do hide dissection. So as soon as you see that happening, you want to stop injecting fluid into the eye, stop increasing the pressure inside the eye, push on the posterior lip of the wound, decompress the anterior chamber. That allows the iris to fall back into the eye. So we are now going to do phacoemulsification. We're going to phacoemulsify this nucleus. We're going to bury the phaco tip into the nucleus. We're going to do a horizontal chop technique with a Nagahara chopper. And we're going to split this cataract into two heminuclei. Nucleus disassembly, you've seen it. You've seen my phaco chop technique in my other surgeries. But basically, once we get the two heminuclei, we're going to split it into quadrants. And I'll either start taking the pieces now or I'll rotate and take them all together. So it looks like here we're rotating. And we're going to chop that second heminucleus into 2/4. And once we've got that nice into 4/4, we can go ahead and start removing these nuclear pieces. I use the same mode throughout. I use my quadrant removal mode setting when I'm impaling the nucleus and chopping it, as well as when I'm eating up these pieces here. So we can see that we've already removed 2 pieces of the nucleus, and we're removing the last quarter here, the 3rd quarter, and now the last quarter. This piece is rather large. It all wants to come together, but it's relatively soft, so the phaco should handle this nicely. This is the Alcon Centurion machine, and we are removing the last piece of the nucleus here. It looks like there are some cortical fragments remaining, or I'm sorry, not cortical fragments. There are some pieces of cortex still attached to the capsular bag, and so we're going to use irrigation aspiration here to remove those. As I'm waiting for my tech to get my IA probe ready for me, I use BSS on a 30-gauge cannula through the paracentesis just to remove any material that may be hiding in the paracentesis. Irrigation aspiration here to remove that cortical material, peel it off the posterior capsule. We did not see a triangle sign here. We did not achieve cortical cleaving hide dissection. And you know what? That's okay. We don't have to get it 100% of the time. We'll use IA to remove the cortical material, and that comes out rather nicely. Once we get that out, I'll often use a Terry squeegee, a cannula with a silicone sleeve, to irrigate and remove any lens epithelial cells that may be stuck to the posterior capsule. Really not a whole lot there. Provisc, we put that to the right and left of the wound. We want to remove any material that may be hiding in the anterior chamber angle. We don't want to have to come back to remove nuclear chips. We fill the posterior capsular bag. We fill the capsular bag with viscoelastic, put in the IOL, and we're going to go straight in with the IA probe to place and center this lens, get those haptics moving, And then once those haptics are moving, that's when we start irrigating, because that cold fluid is going to make the lens unfold even more slowly. So we're on a viscoelastic mode here, lots of movement in the eye. Viscoelastic mode, we start the vacuum at a higher setting, and then before we go behind the IOL, I switch back to cortical removal mode, which has a lower initial vacuum. This looks good. We're going to use BSS to hydrate the wounds. We first of all hydrate the main incision. Here we're just hydrating the wound. We're not really injecting BSS into the anterior chamber. Some of it does go in, but we use the paracentesis to actually fill the anterior chamber. We see there's a little piece of material there, lens material. I'm going to go back in there with the IA to get that out. Once again, if I'm going to go back in through the main wound, I'm going to hydrate that wound again, hydrate the anterior lip, get a nice watertight closure, fill the anterior chamber with BSS, push the IOL back, make sure the optic is behind the anterior capsular leaflets, check the IOP. We're happy with that. We're going to check the wounds with wet cell sponges. And that's a wrap. Questions, comments about small pupil cataract cases, please drop them in the comments below. We're going to be showing a series of small pupil cases throughout the following weeks. Thank you for your attention. Have a great day.